Hi everyone, this is Melissa from Aim at Melanoma. I'm coming to you live tonight to talk about the decision tree or options for treating stage 3 melanoma. If you're there and you can hear me, please hit the like button or the thumbs up or the love button or the laugh emoji, whatever, so that you can let me know you can hear me. I'm going to assume that you can, unless you tell me you can't. So if you can hear me, please let me know by hitting the like button at the bottom of the screen. I'm going to talk very briefly. I set this up as a question and answer format, but please, if you have questions as I go along, please feel free to comment. I'll try to answer them live as best I can. If there's a question that's specific to your case or there's something you don't feel comfortable with me trying to address live, or you think of it later, you can actually call the hotline. That number is 1-877-246-2635, and I will actually repeat that number at the end of this whole live event. Or you can actually shoot me an email through our form that's on the Ask an Expert page on the website at melanoma.org, aimatmelanoma.org. This is a copy of the options for stage 3 melanoma. It's called the decision tree. You can actually access this as well on the website. It's on the Melanoma Learning Center tab. And then when you scroll down, you'll see a little link that says options for stage 3 melanoma. There's a link to the entire document that you can download and actually look at offline. So let's get started. So first and foremost, what is stage 3 disease? That's the whole reason we're talking about this. Stage 3 disease basically means that you have lymph nodes that are positive with melanoma. Or you could have what's called in transit disease, which are smaller lymph nodes that are kind of along the way. So like most lymph nodes, like say I had a melanoma on my arm, a lot of the lymph nodes that would be positive in a sentinel node would actually be under the armpit. Now in transit, lymph nodes would show up somewhere along your arm that didn't quite make it to the armpit, but are from the primary. You can also have something called a microsatellite. Microsatellites are essentially deposits of melanoma that are in the skin around where the primary is. So let's say like this is my primary melanoma. Microsatellites would be somewhere in the environment around it, and those are usually found while they do the wide excision. So stage 3 disease, either an intransit lymph node, something that shows up a little bit further but close to the primary called a microsatellite, or a lymph node under the arm. If you have any questions about your stage or what your pathology means, you can always attach a copy of the pathology report in the form that they send by email to me, and I'd be happy to explain it at any point in time. So any questions like that, please let me know. Okay, so now I've had surgery. Is surgery enough? Is that, what else do I need to do? No, surgery is not enough. In stage 3 patients, what happens is your risk is high enough that you can't just remove the primary tumor. When a lymph node is positive, it has access to the rest of the body. It can spread throughout the lymphatic system. The lymphatic system is closely tied to the bloodstream, and that travels everywhere throughout the body. So even though it started on your hand, if it gets into the lymphatics, it can have access anywhere. Stage 3 patients have about a 2/3 chance of recurrence over the 5 to 10 years. The survival, like at 10 years, about 68% of patients with stage 3 disease can have a recurrence. So we obviously don't want that. We want to cure your melanoma. So what we're targeting with this therapy, or adjuvant preventative therapy, is actually trying to not only treat the disease that would have been in the lymph nodes, but also things that we can't see, or single cells that may have metastasized prior to having your surgery. So surgery is not enough. What should I know? What do I need to know? Connie, stage 3 disease, there's a complete staging guide. Stage 3 disease is tough because it may be a couple of different things. It may be that you have multiple lymph nodes that are involved, like 3 or 4 lymph nodes involved. It could be that you have microsatellites. It could be that you had matted or clumped lymph nodes. If you send me your pathology report with the link on the Ask an Expert page, I'd be happy to explain it fully based upon your actual stage. So, okay, back to the to the thing. What do I need to know before I go to the oncologist? So there's a couple of things that we want to know. It makes our job a lot easier. The most important thing actually in trying to decide a therapy for stage 3 disease is actually BRAF status. BRAF, that's BRAF. It's actually a mutation that's present on your actual cells of your melanoma. It's in 50% of skin melanoma patients. Mucosal melanomas, uveal melanomas, melanomas of the hand and feet or acrolentiginous, they have different mutations that are present. But in skin melanomas, 50% of patients will have this BRAF mutation. The reason that it's important is that, and it's important to know, is that if you give a patient this BRAF MEK inhibitor combination and you don't actually have the BRAF mutation on your tumor, it won't work. So it's really important to know. It's also a test that like a pathologist or a dermatologist or your oncologist has to ask to be ordered. And there's a specific few tests that actually are done. And for it to be accurate, they have to be the right ones. So you want to talk to either your surgeon or the dermatologist or your oncologist about ordering that test because we need to know it. You also want to have complete staging done. Staging means that we want to know, you had surgery, you had a positive lymph node, say, you had your wide excision. Are there any deposits anywhere else in the body? Are there lung metastases? Are there liver metastases? Because that would actually push you into stage 4 and it wouldn't be relevant to do adjuvant or preventative therapy in that setting. So you want to have complete staging either with a PET CT or a CT scan just to make sure that there isn't any distant metastatic disease. If you have questions about that, again, I would be happy to field them as well. But those are the things you want to know. Before you go to the oncologist, your staging through scans, and your BRAF testing. And also you want to bring all your pathology reports because that's important as well, so we know exactly what stage we're working with. What are the options for adjuvant therapy? Well, from 1995 all the way to 2015, there was only one drug that was approved by the FDA, and that was something called interferon. Interferon is essentially a protein your body already makes. It makes you feel like you have the flu. It's a treatment that you would get IV for a month and then give shots to yourself for the rest of a year. It makes you feel like you have the flu, and it actually only has a response rate of reducing your risk of about 18 to 20%. So it's not a super effective way to prevent your melanoma from coming back. Now in 2015, yeah, Carla, it's the worst. So in 2015, there were 2 drugs additionally approved, and then followed by a third and a fourth to treat adjuvant therapy. So like if you had to have a stage 3 melanoma, it's much better that you have it after 2015. So what are the options? There's a combination of pills called a BRAF MEK inhibitor that's called Mekinist and Tafinlar. We're going to talk about these more specifically in a second. The second option from actual therapy is something called Yervoy. It's a CTLA-4 medicine that actually makes your body make tons and tons of T cells. It has a response rate that's a little bit lower. It reduces your risk of recurrence by about 35%. And because PD-1 inhibitors, which is the third option, work a little bit better, they have response rates of about between 50 and 60% of reducing your risk. Oncologists tend to use the PD-1 inhibitors as opposed to CTLA-4 or Yervoy. Now, that's not always the case. So there are actual 4 drugs: BRAF MEK inhibitor, CTLA-4, and the 2 PD-1 drugs. The 2 PD-1 drugs are called Opdivo and Keytruda. And we can talk about those more in depth in a second. You can also do active surveillance. So let's say you are just completely opposed to doing treatment actively with one of those 4 medicines. You can always do active surveillance. Active surveillance would essentially mean that you would go back to your oncologist, every 3 months, have perhaps scans, sometimes a chest x-ray, a complete clinical examination to feel for lymph nodes, look to see if there's any changes on the skin. Now, obviously that would be more in the 60% risk of recurrence profile for most patients. So we always, at least at our center, recommend some type of adjuvant therapy for stage 3 disease. Let's take another look. So how long is this treatment? All of the treatments are for 1 year. That's the way they were tested and FDA approved. Sometimes because of side effects, patients have to come off treatment a little bit early. We don't know exactly how much of that 1 year that you need, but the standard amount of time is 1 year. As far as like the differences between the drugs, the IV treatments, Yervoy, Keytruda, Opdivo, they typically take about 30 minutes to infuse. Yervoy is a little bit longer at 60 to 90 minutes, and it's an IV treatment. The Yervoy and the Keytruda, they actually are once every 3 weeks. The Opdivo is given IV once, well, you can do it every 2 weeks, but also once a month. The once a month dosing is higher, so it was FDA approved at the every 2 week dosing at 240 milligrams, but they also found that doing 480 milligrams once a month was just as efficacious and didn't offer any additional severity and side effects. So you can do it every 2 weeks at a lower dose or once a month at the higher dose. And then the BRAF MEK inhibitors are actually pills. You would take those at home. They are done twice a day. There are some additional monitoring things that you have to do with the BRAF MEK at home, because some people are like, yay, it's a pill, I can go home and take it. But you actually do have to do things like a monthly echocardiogram, lab work. We typically see our patients for the first couple months once a month, just to kind of make sure that everything is going okay as well. So, a little bit different schedule for those options as well. To talk a little more about BRAF MEK, BRAF MEK is sometimes called an IO or an oral immunotherapy. It's Tafinlar and Mekinist. Again, it's a pill. You take it twice a day. You take it for 1 year. Now, the way that this works is it actually helps disrupt the enzymes that allow the tumor to grow. So it's like a blocker is how we describe it to patients, or like throwing a wrench in the middle of your transmission. It's going to not allow it to turn the drivetrain to allow your tumor to grow. There are side effects. About 97% of patients will have some kind of side effect from these pills. So although it's easy to take it at home, you will have side effects of some kind. The most common things are fever, and they can be pretty high fevers, like in the 103 range, fatigue, nausea. There's a rash that develops, and the rash can either be one of two things, and it actually will help us decide which of the two pills is causing the rash. So it can either present as hives, which is more likely to be the Tafinlar, or it can look like acne, which is more likely to be the Mekinist. And your oncologist can actually adjust the medicine and dose reduce if some of these side effects tend to be more severe. So that's one of the other benefits of the pills, is that it can be adjusted to your tolerance level. Again, we already mentioned that you have to get an echocardiogram, and that's because the MEK pill, the MEK inhibitor part, can sometimes cause some issues with the ejection fraction of the heart, or the way that the heart can pump out blood. It's very rare. It happens in about like 1% to 2% of patients, but it is something that we want to keep track of because we don't want that to happen. Alternatively, the immunotherapy, again, we talked about three things: Yervoy, Opdivo, and Keytruda. Yervoy works by taking the brakes off the immune system and making tons of T cells, which are your soldiers that go out and fight. They actually have a higher incidence of autoimmune side effects because in making all of these fighters, sometimes they don't really know the difference between normal tissue and tumor. So they go out there, they're swinging punches at everything, and sometimes cause quite a bit of severe side effects. Again, it's given every 3 weeks, or every 3 weeks for 4 doses as an IV. There aren't guaranteed side effects, like you can get the first infusion, go home, feel completely fine, but it is possible that if you develop one of the autoimmune side effects, that they can be pretty severe. In about 10 to 20% of patients, they can be pretty severe, requiring hospitalization. PD-1, Keytruda, Opdivo, they work by unmasking the cancer cells. So they actually say to the immune system, hey, over here, there's a tumor, you need to get it, because they're very good at hiding. So it allows your immune system to actually see the tumor. That's given, we talked about this already, the schedule is either every 3 weeks with Keytruda or every month, usually with Opdivo. Again, not guaranteed side effects, but you can develop autoimmune things. What are those? The actual most common side effect or complaint of people on immunotherapy is fatigue. About 50% of people will complain of fatigue from these drugs. Then the autoimmune things that can happen are colitis, which is inflammation of the colon, rash, again, that looks almost like hives. You can get hepatitis or inflammation of the liver. That happens in about 5 to 8% of patients. It is something that most of the time your oncologist, because they're drawing labs to monitor your liver functions, will know that. You can also develop thyroid gland issues, adrenal gland issues, and that's also an endocrine or hormonal thing that your oncologist will be following with the labs that he or she draws. There are like 500 other million things that immunotherapy can cause an itis or an inflammation for. All of those are actually listed within the decision tree that you can take a look at as well. If you have specific questions related to any of those things, or you've experienced any of those things, please feel free to drop me an email or call the 1877 number, and I'd be happy to work through that with you. Okay, so do these treatments work? Yeah, they do. They're very effective, especially compared to interferon, in reducing your risk of recurrence. I know I gave you statistics before, but essentially interferon, the old medicine, reduced the risk by about 18 to 20%. BRAF reduced your risk by about 55%. Yervoy only reduces your risk, but still significantly more than interferon by about 35 to 40%. And Keytruda is about a 40 to 50% reduction rate. Is one better than the other? Not necessarily. Your oncologist will take a lot of consideration in deciding your specific treatment plan. There's a lot of things that go into it. What is your BRAF status? How significant was your staging? Like if you were a stage 3A, they might decide to do something a little bit less toxic, take the risk of developing autoimmune things. Whereas if you had a very bulky, aggressive tumor or had stage, say, D, which is matted lymph nodes or microsatellites, they may decide to actually take a little bit more of a direct, aggressive approach with the pills if you're BRAF positive. There's some other things that would actually affect an oncologist deciding to give you immunotherapy because of the risk of autoimmune disease. If you already have an autoimmune disorder like ulcerative colitis, Crohn's disease, sometimes psoriasis, your oncologist may decide that because you can have a flare of those things while on treatment, that they don't want to give you immunotherapy. They may opt, if you have the BRAF mutation, to give you the BRAF MEK inhibitor instead. So it's not a straightforward decision anymore. Back when there was only one choice, we pushed everyone towards interferon because that was all there was besides observation. Now there are a lot of options, which is fantastic and great. And there usually is an adjuvant therapy that's right for you now, which is really promising and wonderful. And it's a decision that you will make together with your oncologist. Connie, low blood sugar can actually occur on Opdivo. They actually think that it's somewhat related to the way that your body processes the insulin within your pancreas, and that's something that they should be checking on you as well. You can also develop hyperglycemia and like type 1 diabetes as well, and there are specific blood tests that you can actually check to see whether that's happening. So those are all things that you can actually monitor as you go along. Okay, so what else do we have to cover? Oh, will insurance cover this? It's kind of a convoluted answer, but yes, insurance will cover this, or you can get help if you don't have insurance. So if you have a private insurance that you buy through your employer or whatever, it will be approved. Sometimes there's a pretty hefty copay with these depending on your plan, but there is actually copay assistance programs that you can get from the drug manufacturer. It's something that your oncology team can help you, paperwork and stuff that your oncology team can help you do. If for some reason you have Medicare, Medicaid, TRICARE, you can't get the assistance, copay assistance program. It's just not allowed. It's part of some rule. But they do have independent charitable organizations that work with the drug manufacturer that will cover patients that have high copays in those situations as well. And that's the same thing. You fill out this pretty much the same form for financial assistance, and they'll place you based upon, you know, your circumstance. For people that aren't insured, you can either get free drug through the drug manufacturer, or there are charitable organizations that will help you get access. Truly, the drug companies are trying to make these adjuvant therapies available to everyone who needs them, and so there's always a way. We've had situations where we just really had a hard time getting drug coverage, and we've reached out to the drug manufacturers and they've worked with us. There are people that they employ to do just this. So don't be discouraged if you're in a bad financial situation. There is always a way to get you medicine to help you. And again, your oncology team and the drug manufacturer, you can even go on their website. There's 1-800 numbers on each of the drug manufacturers' websites that will sometimes have assistance and links to those as well. As far as the oral agents are concerned, they're billed a little bit differently. The oral medications are billed through Part D. Keytruda and Opdivo are billed through Part B if you have Medicare. Private insurances will sometimes make the oral agents go through, well, not sometimes, they will make the oral agents go through a mail order pharmacy. But again, that's something that you and your oncology team will work through. They offer samples to get you through until those drugs come and everything gets worked out. So never fear, everything will be okay. Michelle, you can actually watch it from the beginning once I'm done. It'll get posted on the website, and then you can start it over and watch it from the beginning. So don't worry, you can watch it as soon as I'm finished. Okay, the only other thing that I really wanted to make sure I covered is how will this affect my ability to make new babies and, you know, my family moving forward, or fertility issues. Essentially, they don't know what the interaction would be necessarily with a fetus. So the general recommendation for both the IO and immunotherapy and oral, IV, everything is don't get pregnant while you're taking these medicines, because they don't know what effects it will necessarily have on the fetus. So while you're on therapy, make sure that you're using really 2 birth control methods, you know, whatever you want to do. Both condoms, female contraceptive, whatever that is for you, but very much try to not be pregnant while on these medicines. Some things to also keep in mind, they don't believe that any of this long-term affects fertility. There's not been any data that supports that it does affect long-term fertility. Sometimes with Yervoy and the PD-1 inhibitors, because of the hormones that sometimes get a little bit out of whack, there has been some patients that have described some difficulty getting pregnant, like for the year or so after they stop treatment. We usually try to say, because of the effects of the drug, to not get or try to conceive for about 6 months after the PD-1 inhibitors or Yervoy. Now, for the BRAF/MEK inhibitors, they clear from your system a little bit faster, and so that it's about 4 months that they recommend that you don't take or don't become pregnant. So long-term should not affect your fertility. But while you're actually on active treatment, please do not get pregnant, because the effects are unknown. The other thing that patients always ask, and it's something that comes up all the time, especially in the wintertime, is like vaccines. So as of right now, they know that the flu vaccine is totally okay to get with all of these medicines. There's some debate about the pneumococcal vaccine and also shingles, because some of those shingles are actually a live vaccine. So they tell you while you're on immunotherapy to not get live vaccines, not to get the pneumococcal vaccines. But again, those are things that you can talk about with your oncologist. But that's something that I always try to, every time I talk about these drugs, try to remind people of. So, again, all of this information that we talked about tonight is described in a really, really well written document that is available on Melanoma's website. This is what it looks like. Obviously, it's in color on the website, both in electronic form. I went there and printed this one out. It's options for stage 3 melanoma. It's a decision tree. There's a little guide making decisions. There are worksheets contained within the document that you can print off and fill out kind of to decide what treatment's best for you. You can take those along with you when you go to your oncology appointment. It tells you all the things that you need to know before you get there, talks more in depth about the actual drugs themselves and the risk of recurrence. It's a really helpful document. I've actually started using it in my own practice with our patients to try to help them decide what is best for them. And again, if you have more questions about this, or you have more questions about melanoma in general in terms of anything really, you can feel free to reach me. Again, my 1-877 number is 1-877-246-2635. You can also send me a form with a question that you can attach pictures and things like that to from the website under the Ask an Expert tab. You can also leave comments on here. I'll probably check this for the next couple of weeks just to kind of make sure that we're answering all the questions and comments after the fact. I also want to take this opportunity to thank everybody for listening. I know I sometimes talk really quickly, so if there's anything that needs clarified, please feel free to reach out to me. This is a really huge topic, and so we're actually going to probably at some point put this into a more extensive video, like a webinar, so that I can talk a little bit more in depth and not kind of cover everything in such a small period of time. The other thing that I wanted to make sure that we let you know before I sign off here is that we're going to be doing a piece on BRAF and exactly what that means, and kind of talking a little bit more about how the drugs work, what BRAF is, how they determine it, what tests need to be done, and just really digging in and describing BRAF in a little more detail. In about a month or two, we should probably have that up and running, and so look for that. If there are topics that you want to hear more about, or topics for more Facebook Lives or webinars or whatever, please leave them in the comments. I would love to hear what people want to talk about so that I can come on here and talk with people and answer questions and things like that. So we're really looking for what you want to know about. That's the most important thing. We're here for you and to educate you. So let us know. I hope that everyone has a wonderful night, and I'll see you guys soon. Bye.